All right, let's dive into a super high-yield topic for USMLE Step 1, lymphoid structures. We're going to break down the most testable, absolutely need-to-know concepts that will get you points on exam day.
Our mission here is pretty simple. We're going to take this seemingly complex topic and turn it into a straightforward, easy-to-remember framework. We'll hit the anatomy, the key clinical tie-ins, and those tricky drainage patterns that just love to show up on the test.
So here's our game plan. First, we'll cover the big picture with the immune system headquarters. Then we'll get into the nitty-gritty of lymph nodes, the spleen and the thymus. After that, we are mapping out lymphatic drainage, and then we'll wrap it all up with a quick knowledge check to make sure it all sticks.
Okay, Section 1, Immune Headquarters. So the very first thing you have to get straight is the difference between primary and secondary lymphoid organs. This distinction is the foundation for, well, pretty much everything else in the immune system.
Here's the core concept, nice and simple. Think of the primary organs, that's the bone marrow and the thymus, as the schools where our immune cells go to grow up. This is where B and T cells mature and learn what to attack and what to leave alone. Then you've got the secondary organs, like the spleen and lymph nodes. These are the battlegrounds. This is where those fully trained cells go to actually meet the enemy antigens and start the fight.
Let's move on to Section 2. Now that we've got the big picture, let's zoom right in on the lymph node. This is your classic secondary lymphoid organ, and trust me, it is an absolute favorite for exam questions. Knowing its internal geography is the key. So take a look here. You've got lymph fluid coming in through all these afferent vessels. It trickles through all the different zones inside, and then it flows out through a single efferent vessel. And the whole setup, right? It's all about maximizing the chance that an invading bug or antigen is going to bump into the one specific lymphocyte that can destroy it. First up, the follicle. As soon as you see the word follicle on an exam, I want your brain to just light up with B cells. This is the B cell home base. Primary follicles are kind of sleepy, but once the immune alarm bells go off, they wake up and become secondary follicles with those really active germinal centers inside. Now, right next to the B cell zone is the paracortex. And you guessed it, if follicles are for B cells, the paracortex is the T cell zone. And listen up, because this is one of the highest yield connections you can make. In DiGeorge syndrome, the thymus doesn't develop properly, so patients don't have enough T cells. And where do you see the evidence? Right here, in an underdeveloped, empty-looking paracortex. That's a classic connection they love to test.
And finally, we get to the center, the medulla. This is where the battle's endgame happens. The medullary cords are packed with plasma cells. Those are the activated B cells, and they're just pumping out antibodies. And the sinuses? They're filled with macrophages, basically the cleanup crew, gobbling up all the debris.
All right, let's talk about a couple of specialists, the spleen and the thymus. Each one has a really unique job, and they both come with some absolutely critical clinical tie-ins that you've got to know for your exam.
You can think of the spleen as two organs rolled into one. You've got the red pulp, which is this amazing filter for your blood, yanking out old, beat-up red blood cells. And then you have the white pulp, which you can see here around the arteries. It basically acts like a lymph node, but for your bloodstream, fighting off any pathogens that get in there. So what if someone doesn't have a spleen? This is super high yield. On a blood smear, without that filter, you'll start seeing things like Howell-Joly bodies in the red blood cells. But here's the most critical point. Patients are at a huge risk for infections from encapsulated bacteria. Think strep pneumo. Why? Because the spleen is the primary place where those slippery encapsulated bugs get tagged and destroyed.
Now let's move on to the thymus. This is that primary organ where our T cells go to school. It sits up in the chest, in the anterior mediastinum, and it's biggest when we're kids. You're looking at the classic sale sign on a baby's chest x-ray, which, by the way, is a completely normal and healthy finding.
When you think about thymus pathology, I want two things to just lock into your brain. First, thymoma, a tumor of the thymus, is very strongly linked with myasthenia gravis. It's a can't-miss association. Second, an absent thymus, well, we've already talked about it. It's the classic finding in DiGeorge syndrome, and you also see it in SCID.
Okay, time to switch gears to something really practical and clinical, lymphatic drainage. Seriously, if you know these pathways, it's like having a clinical roadmap that can predict how an infection, or more grimly, how a cancer is going to spread through the body.
So this gives you the 10,000-foot view. Just notice this major split. Pretty much everything from your right arm and the right side of your head goes to the small right lymphatic duct. The entire rest of the body, it all funnels into that big thoracic duct. Now let's zoom in on the specific nodes they'll ask you about. So above the diaphragm, a few key players.
The axillary nodes, of course, are huge in breast cancer staging, but the one you absolutely cannot afford to forget is the left supraclavicular node. We call it Virchow's node. Think about it. It's the end of the line for the thoracic duct, which drains the whole abdomen. So if that node pops up, it can be the first physical sign of a cancer deep inside, like gastric cancer.
Now, below the diaphragm, please remember this classic exam trap. The testes drain back up to the para-aortic nodes, not the nearby inguinal ones. Why? Because embryologically, that's where they started out, way up in the abdomen. The scrotum on the outside, though, that goes to the superficial inguinal nodes. They love asking about that distinction. All right, we have covered a ton of ground. So now, let's lock it all in. It's time to test yourself with a couple of USMLE-style questions. This is where you really start to own the material.
Okay, take a second and think it through. What are the key clues here? A kid with viral infections and in the lymph node. That specific area between the follicle and medulla is underdeveloped. What's that pointing to?
And the correct answer is C, the thymus.
See how it all connects? That region between the follicles and medulla? That's the paracortex. That's the T-cell zone. And where do T-cells mature? The thymus. And who fights off viruses? T-cells. So a weak paracortex plus viral infections equals a problem with the thymus. It's a perfect logic chain.
All right, here's our last one. This is a classic clinical picture you might see on the wards. Older guy, losing weight, and you find this one specific hard node just above his left clavicle. What should be at the top of your mind?
And the answer here is D, stomach.
This is a direct payoff from knowing your lymphatic map. That left supraclavicular node is Virchow's node, the sentinel node. It's the collection point for the thoracic duct, which carries all the lymph from the abdomen. So if it's enlarged like this, it's often a sign that something bad, most classically gastric cancer, is happening down below.
So you see, it's all about making connections. Understanding the structure, the function, and the drainage isn't just about rote memorization, it's about building a mental framework you can use to diagnose patients. Keep thinking that way as you study. Thanks for tuning in, and good luck with your prep.